إن شاء الله نبتدي السيشن. We'll start with the milestone of this conference, Professor Manal Al-Mahdi, my dear colleague and my dear friend. She is the Professor of Pathology at Ain Shams University and the Director of the Pathology BGICC Conference, Pathology Section, and I am proud to introduce her to present the session, inshallah. Please, Dr. Manal.
بسم الله الرحمن الرحيم. أحب أرحب بحضراتكم جميعا في الباثولوجي كورس. الحقيقة أنا سعيدة جدا بوجودكم. السنة دي هي السنة ال15 للPGICC، يعني هي عيد ميلادنا ال15. فيعني أحب أرحب بكل أصدقائي وأساتذتي وزملائي بمناسبة الانيفرساري ده. Dear colleagues and friends, welcome to the annual PGICC pathology course. This year is a special one, marking the 15th anniversary of the PGICC. As always, it's a pleasure to welcome you all to yet another fruitful year. I would like to welcome all our international guest speakers who join us during our conference. From USA, we have Professor Ezekiel Sahin, Professor of Breast Pathology, MD Anderson, Professor Joseph Carlson, Professor of Pathology, University of Southern California, USA, Professor Daniel Boher, Professor of Pathology, University of Basel, Switzerland, and Professor Mohammed Dusui, Professor of Pathology, Roswell Park Comprehensive Cancer Center, USA. From Europe, we have Professor Abeer Shaban, Professor of Breast Pathology, University of Birmingham, UK, Professor Cecily Queen, Consultant of Histopathology, St. Vincent University Hospital, Dublin, Ireland, Professor Joseph Vialli, Head of Breast Pathology, Milan University, Italy, and Professor Frédéric Pinault, Professor of Pathology and President of Unicancer Immuno-Oncology Group from France. We have also Professor Maisa El-Hosseini, King Hussein Cancer Center from Jordan. This conference wouldn't have been made possible without all the chairpersons and moderators. Therefore, I would like to thank everyone who helped make the PGICC a successful conference 15 years in a row. Of course, we will be following our schedule in a timely manner, and all questions will be postponed to the Q&A discussion timing. As not to cause any disruption, please make sure your mobile phone silence or switch it off. I hope you all enjoy the course this year with hopefully many more years to come. Thank you.
Good morning. I'd like to present Professor Dr. Abeer Shaban, consultant pathologist. She's a specialist in breast at Queen Elizabeth Hospital, Birmingham, and Professor of Cancer and Genomic Science, University of Birmingham. She's led a number of research studies and contributed to breast cancer trials as co-investigator. She's a member of a trial management group and a central pathology reviewer. She was a member and chair of the NCRI Breast CSG for 2 terms. The subgroup produced several landmark publications, including guidance on improving the turnaround of HER2 testing, manufacture and reporting of tissue microarrays, and handling of new adjuvant chemotherapy cases. She has published over 170 peer-reviewed papers and contributed in a number of book chapters included in the WHO Blue Book for Breast Tumors, 2019. She co-edited a textbook of molecular pathology entitled Molecular Pathology for Practicing Surgical Pathologists and Cytopathologists, and the ICCR guidance for ductal carcinoma in situ reporting. Thank you.
Assalamu alaikum, everyone. Thank you for this very kind introduction. And thank you to Professor Manal for inviting me. I've previously contributed to this meeting online, but that's the first time I came in person, and I was pleasantly surprised by the beauty and the magnitude of this meeting. Really, really something to be proud of, so congratulations to the organizers. I would like to talk you through some updates on the management of B3 lesions. And B3 lesions of uncertain malignant potential are interesting but challenging, and it's an area that has been evolving over the last decade. When we talk about B3 lesions or lesions of uncertain malignant potential, it includes a heterogeneous group of lesions. Some of them are atypical, some are not. So this is generally a list of the most common one. Flat epithelial atypia, atypical intraductal proliferation, which is equivalent to atypical ductal hyperplasia, ADH, but on core biopsy, we prefer the term atypical intraductal epithelial proliferation till you get the whole thing and examine it and assess the extent. In cytolobular neoplasia, to include ALH and LCIS, papillomas, radial scars, cellular fibroepithelial lesions where the differential of Phyllodes tumor is considered, mucocele-like lesions, and some other miscellaneous lesions like bland spindle cell lesions of the breast, apocrine atypia, vascular lesions, adenomyoepithelioma, myofibroblastomas, and so on. So what is the significance of these lesions? This is a summary of the upgrade rate following the further tissue sampling of B3 lesions. And generally, the upgrade rate to in situ or invasive malignancy is about 20%. And these are some examples of the largest publications in the field. So what affects what are the factors that affect the upgrade into in situ or invasive malignancy when we diagnose B3 lesions? Depends on the patient population, whether we're looking at screen detected or symptomatic patients. Methods of biopsy, whether it is a conventional needle core or vacuum assisted biopsy, so the gauge of the needle, the more you sample, the more you're likely to identify atypia and verify the diagnosis. The combination of lesions, so for example, flat epithelial atypia on its own has the lowest upgrade rate. If it's combined with atypical intraductal proliferation, that's higher at about from 11 to 19%. If you have atypical intraductal proliferation on its own, that's the highest, about 45% upgrade. Size of the lesion, but by far, the most important factor that predicts the upgrade rate is the presence of atypia. And this is a systematic review and meta-analysis of the published literature, including 125 full-text studies, looking at the total upgrade rate for B3 lesions of around 17%, with atypical intraepithelial proliferations, or ADH, having the highest risk. And the authors concluded that the risk can be managed by vacuum-assisted excision, so no need really for surgical excision, as was the standard. This is just to show you the atypia. If you look at the blue bars, radial scar without atypia will have the lowest upgrade, while when you have atypia, the upgrade rate goes very high. Similarly, papilloma without atypia, very unlikely to get malignancy when you further sampling, but if you have atypia, up to 37% of cases, you will identify malignancy. And as you know, as pathologists, when we talk about atypia, we either talk about cytological atypia without architectural disturbance, as in flat epithelial atypia, so one or few layers of atypical cells, or complex architectural and cytological atypia where we have some abnormal patterns. And this is a really nice paper, like a bit old, but really nice, on the fauna-like changes in the breast where you have some animals or abnormal architecture presenting like almost an elephant or a horse and so on. So it confirms that this is abnormal architecture. Traditionally, B3s have been managed by surgical diagnostic excision because they are heterogeneous lesions and they can be associated with malignancy. So on their own, they are not malignant, but we sample them because we know that in a proportion of them, there will be associated in situ or invasive malignancy. If we leave them for a long time, a small proportion will progress and usually progress to low-grade invasive cancer. So what we need to do is to adequately sample to rule out coexisting malignancy. And these are the UK guidelines that we work to, published in 2018 by the B3 Guidelines Writing Group, which recommended second-line VAP, or vacuum-assisted excision, VAE, as the method of choice for further sampling of the majority of B3 lesions. Not all of them. So we cannot really get rid of surgical excision totally, particularly if there is a radiological pathological discordance. But we try to have this as the gold standard, and the exception will be few cases. So we do surgical excision in cases of papilloma with atypia. So benign papilloma will be managed by VAE. If there is atypia, we would go for surgical excision. And the reason for that is that we need to assess the lesion intact, assess the extent of atypia, and if atypia is 3 millimeters or more, we call it DCIS in a papilloma. And that's why we need to see the whole thing intact. If we have cellular fibroepithelial lesion, so where you are suspecting phyllodes, for example, we would like to assess the whole thing intact because we need to assess the margins of the lesion. And other uncommon or miscellaneous B3 lesions, such as spindle cell lesions, vascular lesions. So these are generally managed by surgical excision. And we have a really very useful guideline for radiologists with this useful table of a list of B3 lesions with the risk of upgrade and the recommendations for management and also the suggested follow-up. Generally, if there is atypia, we would follow up every year by mammography for 5 years. So this is generally if there is atypia, whether it is FEA, ALH, LCIS, and so on. And this is an example of the schema for managing B3 lesions, all within a multidisciplinary approach. That's really essential, that the multidisciplinary team will come together, will discuss the findings in the core biopsy or diagnostic VAP and plan what the next step is. So we start with either a diagnostic VAP, standard core, or standard core. So either if you get a B3 lesion, you go for vacuum-assisted excision. And we recommend as a measure of accuracy or adequacy of sampling to have at least 4 grams of tissue to say that we've adequately sampled the lesion. So if you find no additional atypia, we would go for MDT discussion and generally go for annual mammography. If there is further atypia, we would assess, is it up to DCIS or invasive disease? Then we would go for therapeutic surgery, so wide local excision and so on. If there is additional atypia but not amounting to DCIS, again we discuss in the MDT, and we can plan for surgical diagnostic excision or annual mammography depending on pathological and radiological findings. And the subsequent management would rely on the surgical findings. For the miscellaneous B3 lesions that go straight away for diagnostic excision, we would go for MDT discussion. VAE would not be recommended, and we would go for surgical excision and then manage as per the findings. What about the other international guidelines? This has been a field of a lot of interest and guidelines. So the European or Swiss guidelines provided the first international consensus, followed by the second, and the third was held recently in September last year, and my colleague, Professor Cecily Quinn, was part of this. And basically, this is done by getting the experts together, looking at the evidence and voting on each lesion, and they publish the guidelines. So this is pending, and the third consensus guideline will be published soon. The difference compared with the UK guidelines is that if you find ADH, or atypical intraductal epithelial proliferation, this is managed by surgical excision. And many places actually support that, like in the US, if there is ADH, they would go for excision. In the UK, we would do second-line VAB as well, because we would then upgrade either to DCIS or keep it atypia, and then plan. And Phyllodes tumor is excised as per all the guidelines. These are the German guidelines, AGO recommendations, published end of last year, and they recommend open biopsy for ADH, florid and pleomorphic LCIS, and we'll cover this shortly. And interestingly, that's the difference among the, compared with the other groups. They recommend extensive sampling for flat epithelial atypia, and if they cannot remove more than 90% of the calcification, they recommend excision. In the UK, we would just go for VAE, and if there is extensive calcification, we normally sample two areas, the two most suspicious areas. Just to let you know that these are guidelines that are in development now, and this is from the European Society of Mastopathy, and these are coming out. I have been involved in these, and the team have already met for the consensus meeting, and these are supposed to be evidence-based guidelines to be international. As you saw, there is difference in the UK, European, American, and even Australian guidelines. So the plan is that these will be international guidelines, and these are supported by several groups, USOBI, European Society of Pathology, BRESO, and so on. This is a very recent paper on the effect of COVID on the B3 lesions, and whether the delay in our excision resulted in any increase in the upgrade. And this was reassuring to show that this didn't happen actually, that delayed sampling of B3 lesions did not increase the upgrade rate during the COVID time. So to go quickly through the most important B3 lesions, FEA. So what is FEA? It's dilatation of the terminal ductolobular unit lined by atypical cells. So they change from the usual columnar lining into cuboidal hyperchromatic or rounded. The cells can be slightly variable in size, but not high grade. And the ducts are lined by cells that are low grade, similar to low grade DCIS. If there is, on top of that, architectural atypia, then this is not only FEA, this is ADH or DCIS, depending on the extent, on top of flat epithelial atypia. And remember that this definition does not apply to high-grade lesions. If you have a flat lining with high-grade nuclei, this is high-grade DCIS, it's not flat epithelial atypia. Immunohistochemistry, unfortunately, is not helpful. You're on your own. It is a morphological diagnosis because the immunoprofile is similar to low-grade DCIS. When there is associated architectural atypia, then this is FEA and AIDP. And in the UK, we tend to use atypical intraductal epithelial proliferation terminology on core biopsy and VAP. We do not call it ADH on core. And that's because ADH diagnosis is quantitative. It has to be less than 2 millimeters. And you cannot be sure on core biopsy that that's the case. So we wait till we assess the whole lesion and then designate it as ADH or DCIS. So management of columnar cell change on core biopsy, we always examine at 3 levels. If it's non-atypical, what we call columnar cell change only, this is B2 and nothing else is required. If atypical, FEA, AIDP, then this is B3 and further tissue examination is needed, and this is done by second-line VAP. If it's high-grade cytological atypia, it's B5A, flat DCIS, and on excision, with atypia, we would sample well to exclude coexisting disease. And the reason is that flat epithelial atypia and ADH are thought to be the precursor of the low-grade neoplasia family and the low-grade invasive ductal, mucinous, tubular. So these are the ones that we look out for when we sample more. Molecular diagnosis, the molecular profile of FEA is very similar to low-grade DCIS, characterized by 16q loss, so the low nuclear grade neoplasia family. ADH, quantitative diagnosis, not high grade, is B3 on core, and we designate it as atypical epithelial intraductal proliferation. So, characterized by architectural atypia and cytological atypia. So when do we call it DCIS and not ADH? The cutoff is 2 millimeters or 2 fully involved ductal spaces. So that's the cutoff to designate as DCIS. Remember that in papilloma, we increase the cutoff to 3 millimeters. Unfortunately, we know that we're not very consistent in the diagnosis of ADH, and this is data from the UK External Quality Assurance Scheme, which shows only moderate agreement in the diagnosis of ADH. But part of it is that we do it on sections, serious sections, so we cut quite a lot. So, and you know that ADH is a focal lesion, so some slides have the lesion, some do not. And we've now moved to digital, so hopefully this degree of low consistency will disappear. So ADH or AIDP is associated with the highest risk for development subsequent cancer if further sampling. This is a very recent paper from the Memorial Sloan data that showed that when they diagnose ADH bordering on DCIS, they have the highest upgrade rate, 40%. In the UK, we tend to call these B4 when we are suspicious of malignancy. So when it is almost there, but you don't have enough. So management of AIDP on core biopsy, we call it B3. In the UK, we would go for vacuum-assisted excision, but in other places, they go for surgical excision. If ADH is immediately adjacent to what we designate as DCIS in the surgical excision, we regard it as part of the lesion. But if it is an isolated lesion, even at the margin, we wouldn't go back and clear the margin. So classical lobular in situ neoplasia, postmenopausal disease, we know the morphology and discohesion, and that's what it looks like. Type A, where you have very monotonous cells filling and distended terminal duct lobular units, and type B, which is more cytoplasmic and more variable. The clue is discohesion, and if in doubt, do EC adherent, and this should be negative in the proliferation to differentiate it from DCIS. A good pointer is that the myoepithelial layer is positive, so this is your positive control there, so you know that it has worked. What's ALH compared with LCIS? Again, depending on the extent, if more than half of the acini are distended and distorted by the lobular cells, then this is LCIS. On core biopsy, don't bother. You don't need really to make the distinction. Just call it in situ lobular neoplasia, B3, and managed by vacuum-assisted excision. So management is exactly the same. Even if it is incidental, it's still B3. And this is a paper to show that the outcome of ALH is very similar to LCIS, so there is no need to distinguish in the core biopsy. Traditionally, we've always believed that LCIS risk is bilateral, multifocal, and the patient will develop cancer equally in both breasts, until recently when it was shown that actually cancer is 3 times more likely to occur in the same breast than in the contralateral breast. So yeah, there is bilateral risk, but it is higher in the same breast with the diagnosis of ALH. So what about pleomorphic LCIS? A relatively recently described lesion, very similar to high-grade DCIS. So if we're not aware of it, we will just call it high-grade DCIS. It can be associated with necrosis and calcification, but this is not an essential criteria. Why this is not DCIS? It's because of the discohesion here. And if in doubt, do E-cadherin immunohistochemistry, and this confirms that this is a lobular proliferation. We call it pleomorphic because of the grade of the nuclei. It has to be high grade. And it is important because we manage them differently. So PLCIS is B5A and treated as high-grade DCIS. And the upgrade rate as well is different. So the upgrade rate for pleomorphic LCIS is higher, around 41%. And this is just another paper, a recent meta-analysis showing the upgrade rate of lobular neoplasia. In all the guidelines now, pleomorphic LCIS is managed as per high-grade DCIS. So the NCCN, the UK, and NSBSP, ESMO, all the evidence show that and recommend excision with margin. And this is an audit we did in the UK, and this is the largest series in the UK of 179 cases of pleomorphic LCIS. We found that the mean age is older than in classic LCIS, so similar to DCIS. Associated cancer is predominantly lobular and grade 2. The majority of cases are ER positive, HER2 negative, and the upgrade rate, if it is found on core biopsy as a pure lesion, is about 32%. This is an anomaly, so if you're following the recent AGCC or the TNM, the latest edition, you will see that LCIS was removed from the staging, and they said that there isn't much evidence to support it being a true cancer, and they call it risk. So it is removed from the classification as in situ disease. We don't do that in the UK. We still call it in situ disease, and particularly PLCIS and also florid LCIS. In the WHO book as well, they recommend treating PLCIS and florid LCIS by surgical excision. So clearly, we don't think it is just a marker of risk. It is malignant. These are the guidelines in the UK. B5A if PLCIS. If it is on the surgical margin, we would go back and excise. Florid LCIS, similar to classic and pleomorphic, but it mimics low and intermediate grade nuclei. So if you have a big proliferation, solid like this, without any combination, without cribriform micropapillary, suspect LCIS. So this would be the florid one. There is very little stroma in between, can be calcified and necrotic, and do E-cadherin to confirm. Rate of upgrade is higher than classical LCIS in all the studies so far. There are no standardized guidelines, but the evidence now supports that it should be managed by surgical diagnostic excision, similar to low and intermediate grade DCIS. So that's the way in the UK, Europe, and this is a recommendation of the WHO book. So just to summarize, classic LCIS is B3, PLCIS is B5A, florid LCIS in the UK we call it B4, in Europe they just call it B5A as in situ carcinoma. Some practical issues, first line VAP is a diagnostic biopsy, but second line VAP is almost equal to surgical excision. We do not provide a final B coding after a VAE because we think it is similar to a diagnostic excision. So that's why we rely on our colleagues, the radiologists, to tell us whether the biopsy is first line VAP or second line VAE. And this is to show you the sizes. So that's the conventional core, first line VAP, and this is a second line VAP. Sometimes, particularly if you're dealing with screen-detected lesions and small lesions, they can be excised by VAP. And then when you take more tissue or excise, you wouldn't see any lesion. In these cases, important to insert a marker clip and look for a marker clip reaction and look for previous biopsy and to make sure that the right area has been sampled and review the original biopsy if needed. Marker clips are very important. And the type of marker clip determines what you see histologically. So this is a common type of marker clips that looks down the microscope as cystic lesion with histiocytic reaction. This is another type. And this is the hole in a surgical excision after mammotome biopsy sampling. Sometimes sizing of the lesion can be difficult because you're dealing with it in piecemeal rather than the whole thing. And this is a list of some relevant publications, light reading in your leisure if you're interested. Thank you.
Thank you, Professor Dr. Abeer Shaban, for this very interesting talk. Thank you very much.